Welcome to Living with Lynch 2020. My name is David Dubin, and I am alive and kicking. I wanted to do some introductions so you can meet the group that put this together. So I'm going to introduce them, and they'll do their own introductions, and then we'll get started. So with us today, the organizers of the event, we have Heather, Erin, and Robin. So why don't you guys introduce yourselves real quick?
I'll start. I'm Erin Peterson. I'm the Mission and Partnerships Director at the Colon Cancer Coalition. We are excited to partner with Alive and Kickin' on this Living with Lynch patient workshop, and thank you everyone for joining us today.
I'm Robin Dubin. I am the Executive Director of Alive and Kickin'. We're very excited to bring this to you today, and thank you to Dave and Erin and Heather Hampel for being amazing partners and working with us on this.
And I'm Heather Hampel. I'm a cancer genetic counselor at Ohio State, and I do a lot of research on Lynch syndrome. And we were originally going to host this in person at Ohio State, but we pivoted because of the pandemic, and we couldn't be more happy with the response. So glad to be here.
Awesome. Thanks, guys. So again, my name is Dave Dubin, and for those unfamiliar, I am the co-founder of Alive and Kickin' along with Robin. I am, in fact, the Lynch syndrome patient. I have MLH1, and I am, in fact, a 3-time cancer survivor, having had colon cancer at 29, 40, and a kidney tumor at 42. So this is obviously something that's very near and dear to our hearts. And we're looking forward to sharing this with you. So we're going to get started real quick. So each segment will be comprised of a patient story, a provider talk, and a Q&A. All questions for the Q&A should be entered into the chat box on the Zoom. I think most of you are on that. The presentation will be recorded and shared later on. If you know of anyone that didn't get to register, this presentation obviously is streaming live on Facebook, on the Colon Cancer Coalition, as well as the Alive and Kickin' Facebook pages. Also, as a reminder, this is being recorded, so the sessions will be available in the next week or so. So we have some sponsors that we, of course, will need to thank, and we should thank. Merck and Foundation Medicine, thank you for sponsoring us and allowing us to do this. It is truly appreciated. So we do have a social media presence, and this is going to be important for continuing to get the word out. So please take screenshots, tweet along with us. We will be using and following the hashtag Living with Lynch throughout the afternoon. So we do expect to see that out there. So please tag us, use the hashtag Living with Lynch, and let's make a big deal out of this. Our first topic, let's jumping right in, is genetic counseling and genetic testing. So we'll be featuring Elise Azriel, a Lynch syndrome previvor and future genetic counselor. Looking forward to that. And Heather Hampel, who is the Associate Director, Division of Human Genetics, Associate Director, Biospecimen Research, Professor Licensed Genetic Counselor at the Ohio State University Comprehensive Cancer Center. And remember, a live question and answer period will be held following the presentations from Elise and Heather. Submit your questions in the chat feature on Zoom. And if you are listening on Facebook, we will do our best to get any questions submitted in the comments section as well. And for that, I will take a deep breath and let the ladies start.
Hello, thank you all for coming to the Living with Lynch webinar today. I'm so excited to be the first patient to talk about my Lynch syndrome story. So my name is Elise. I am 27 years old, and I am a therapist here in the Chicago area at a nonprofit. So my story really begins about 2 years ago. Like a lot of people, it was pretty popular to do genetic testing, the direct-to-consumer tests, and I was somewhat familiar with the BRCA gene and breast cancer and things like that, and so I figured, why not do it? I think it was on sale. So I did that, and it came back and it was completely negative. And I thought, okay, great. I know that I have a healthy body and it's working correctly, so we're all good. Then about a year later, last summer, 2019, I was just having my annual physical with my doctor. And she told me about how Color Genetics had partnered with North Shore University Health Systems, which is where I go see the doctor, and how they were doing this DNA 10K initiative. And that the idea was to have 10,000 patients have their genetics tested, and that it was all free to the patients, which I thought was really cool. And so at first she was asking me if I wanted to do it, and I was like, well, I already did that direct-to-consumer test and it said nothing, so why would I do another one? That seems kind of like a waste. And she explained to me that with my family's history of colon cancer, my dad had colon cancer when he was in his late 40s, and then I have other folks in my family too that have struggled with cancer. And so she said she would really recommend it because this test would look at a lot more than what the direct-to-consumer tests were. But of course, she left it up to me if I wanted to do it. But I'm a total science nerd, and so I was like, yeah, it's free, and I would love to find out. And so I did that genetics test, and it was funny, a few days later, I actually was getting lunch with my mom, and she sees the same primary care physician as I do, and she had just gone in for her annual physical and did the same thing, but a little bit before I had. And so she already got her results back that she was negative. So in my mind, I was like, oh, okay, my mom's negative, I'm going to be negative too, nothing to worry about. So I think it was a few weeks after that, I get a email from Color saying that they want to schedule a time to talk to me. I call my mom up and I'm like, Mom, did they schedule a time to talk to you? And she said no. So it kind of raised a red flag that there might be something on there. And so of course, when I talked to them, as we all know at this point, they did tell me that I have Lynch syndrome. I have a mutation of the MSH6 gene. And they went into a little bit about what that meant, but really encouraged me to talk to my doctor and maybe see a genetic counselor about that. So my primary care physician, and again, she's wonderful, she calls me up, she's like, I'm so sorry, and gives me a whole list of wonderful doctors to meet with. So first she sent me to the Center for Personalized Medicine at North Shore, and so I went there. I met with an amazing genetic counselor and an amazing oncologist. Their team there is so wonderful. And so they explained what Lynch syndrome meant and what that meant for my future, and that really, at this point, there's a good chance I didn't have any cancers, that I really just needed to do these baseline screenings, and they listed them all out for me. They told me which doctors to meet with, and they really put me at ease. I was, of course, very anxious. You find out you have this genetic disorder that might now lead to having cancer earlier on in life, and that's not great news to get. But they did such a great job at making me feel better about that news. So then they explained that this is an inherited cancer disorder, genetic disorder. And so I started thinking about that. We probably know it came from my dad because he had colon cancer, but what about my brother? So my brother has autism, and I was really, really nervous that we were gonna find out that he had it, and he already had so many struggles in life, and that this was gonna be another thing that he had to worry about. And so I really started getting most worried that my brother was gonna have it. I started really researching. I put my I got my undergraduate degree in biology, and so I put my biology hat back on. I started researching, finding out as much as I could about Lynch syndrome, because I was like, if anybody has to explain this to him, I would like to try to help him understand what's going on. So I was doing tons of research. And then we found out he did get genetic testing. He is negative. So huge sigh of relief there. But through all this research and then being a therapist, having my master's in counseling, I started to put it together. Like, I really love researching about this and finding out more about genetics and different genetic mutations too, not just Lynch syndrome. And I was thinking about, you know, I wonder what resources there are out there for people with disabilities or mental health challenges that then have a comorbidity with a genetic disorder. And I was wondering if there really was an area of genetics that might be able to cater to these individuals that maybe need a little bit more specified counseling. So I started talking to genetic counselors and shadowing and observing and asking them questions and getting super excited about the field. It's just so fascinating to me that this one little genetic mutation on one gene in your body can make such a huge difference to your life. And I just became really fascinated with all of it. And so after going through all of that, finding out I had Lynch syndrome, my passions for working with people with disabilities and mental health challenges, and then shadowing, I decided that I want to become a genetic counselor. And along the way, I've met amazing genetic counselors like Heather, who you guys will get to hear from too. And I'm super excited about possibly getting into this amazing field. So, you know, I'm so glad that my doctor encouraged me to get the genetic test, even though I thought, why would I do that? I already had one. And I think it's so important that we continue advocating for these genetic tests that really look at the whole genome and not just little specific genes, so that people can find out what's going on with them. So I want to say a huge thank you to Alive and Kickin' and Colon Cancer Coalition for hosting this awesome event. I'm so excited to learn and hear from the other patients today. And I thank you guys for listening to my story, and I'm excited for your questions. So I hope you all have a great rest of your day, and I'll talk to you soon.
Hi, everyone. This is Heather Hampel, and I am so pleased to be with you guys today. I know we had hoped to meet in person in Columbus for this Living with Lynch event, and I hope we get to do that next fall. But the plus of doing this virtually is that we have over 300 people registered, and that is so exciting. I'm really looking forward to this whole day, and I really just love the format with the patient speaking first. And so Elise has really set this up perfectly. And I'm going to talk today about genetic counseling and how we can identify more individuals with Lynch syndrome. So as you guys know, Lynch syndrome is much more common than people previously thought. We now have estimates that 1 out of every 279 individuals in the general public has Lynch syndrome. And if you take that times the population of the US, that means there's actually 1.2 million people with Lynch syndrome in the US alone. So it's an inherited condition that causes high risks for colorectal, endometrial, and several other cancers, as you guys know. But the key thing is that these are preventable cancers with earlier and more frequent screening, or with risk-reducing surgeries in the case of the endometrial and ovarian cancers. So what's really disturbing is that current estimates are that around 90 to 95% of individuals who have Lynch syndrome are not aware of their diagnosis. And if you don't know you have Lynch syndrome, you can't do earlier and more frequent colonoscopy or consider a hysterectomy after you're done with childbearing. And so there's nothing you can do to prevent the cancers from occurring. So I want to talk today about how we can diagnose individuals with Lynch syndrome. So there are three general approaches. One is family history-based referral guidelines. So this is kind of the old-fashioned way. And this is really the only way, well, not the only way, but one of the only ways to diagnose unaffected individuals with Lynch syndrome. And so these are criteria-based. There's criteria that we use to decide who needs to be referred to see genetics and consider genetic testing. We also, through family history, do cascade testing in known Lynch syndrome families. So if we know somebody has Lynch syndrome, obviously at that point it becomes imperative that we offer testing to as many of their at-risk relatives as possible. And that's a part of this testing where you guys can come in and help out, and we'll talk about that. The other approach to identifying people with Lynch syndrome is to screen all colorectal and endometrial and maybe even other cancer patients for Lynch syndrome at the time of diagnosis. And there are two ways to do this. One is kind of what I've spent most of the last 20 years working on, and that's universal tumor screening for Lynch syndrome. So that's a tumor screening test that tells us whether a patient's more or less likely to have Lynch syndrome that we'll talk about today, and you guys have probably heard of, using mismatch repair deficiency as kind of a marker. But we also could just offer germline genetic testing to all cancer patients or subsets of cancer patients. And I want to talk about that as a potential way to identify individuals with Lynch syndrome. And then a third pronged approach is a new approach that's being considered, and that's actually simply doing population screening. So that's offering germline genetic testing to essentially the general public. You don't have to have any family history or a cancer, and you get offered testing exactly the way Elise got tested. And I'm going to give you some results from two studies that have done this, Healthy People in Nevada and the Geisinger MyCode study, that kind of shed some light on how useful this could be. So starting with the family history guidelines, it usually takes a lot of cancers to get referred based on your family history. So you have to have, you can meet one of the two famous criteria for suspecting Lynch syndrome. One is called the Amsterdam criteria, and they were revised and are called the Amsterdam 2 criteria. People remember this as the 3-2-1 rule. You have to have 3 cases of colon or other Lynch syndrome associated cancers in the family. At least 2 generations have to be affected, and one of the individuals has to be a close relative, what we call a first-degree relative, parent, sibling, or child of the other 2. And one also has to be diagnosed under age 50. Those were a little strict, so they made looser criteria called the Bethesda guidelines. And these are very colon-centric, but they have to do with having a colon cancer at a young age of diagnosis, 3 cases of Lynch syndrome associated cancers diagnosed at any age. So that gets rid of the 2 generation requirement and the 1 being under 50 requirement. Or you can have colon cancer plus 1 relative with a Lynch syndrome associated cancer, as long as one of the 2 people is diagnosed under age 50. And more recently, people are using a computer-based model called PREM5, which is available online. Here's the URL, and you can enter your family history very quickly, and it spits out a % chance that you would have a mutation in one of the Lynch syndrome genes. And they recommend referral to genetics if you have more than a 2.5 or 5% likelihood of having Lynch syndrome. So how well do these family history criteria work? Well, it turns out they actually don't work that great. So Amsterdam 2 criteria are only 28 to 45% sensitive. That means that they miss more than half of the people who have Lynch syndrome. They don't meet the criteria, and so they would be missed. They are very specific, so people who meet the criteria do often have Lynch syndrome, but lots of people have Lynch syndrome who don't meet the criteria. Bethesda guidelines, being a little looser, are a little bit more accurate, about 73 to 91% sensitivity and 77 to 82% specificity, but you can see that many people who meet the criteria don't have Lynch syndrome. Lots of people who don't meet the criteria do have Lynch syndrome. PREM5, it depends if you use the 5% threshold. That has the best sensitivity and specificity at 73%. At the 2.5% threshold, it's very low specificity and higher sensitivity. And so most people think that the 2.5% threshold is appropriate for people who are unaffected with cancer, but for individuals who've had cancer, you really need to use the 5% threshold. So moving on from family history-based criteria that warrant referral for genetic counseling and testing, we will talk a little bit about cascade testing. And so this is obviously offering testing to at-risk relatives of an individual who knows they have Lynch syndrome. And we typically start with the first-degree relatives. So those are parents, brothers, sisters, sons, daughters. I'm going to call those FDRs for short. So first-degree relatives, as you guys know, have a 50% chance of also having Lynch syndrome. And so they really, very importantly, need genetic testing once we identify someone with Lynch syndrome so that they can get the appropriate surveillance. And then, of course, if they're positive, their children become at risk, and they need to be offered testing as well once they reach age 18. So you kind of follow the mutation through the family, moving from the positive first-degree relatives to the at-risk second-degree relatives as indicated. So, for example, you would only test nieces and nephews of a brother or sister who test positive. You don't need to test the nieces or nephews through a brother or sister who tests negative, because the mutation will stop there. And so you follow this mutation through the family. And then even moving out to third-degree relatives like first cousins, after you know which aunts or uncles have the mutation, they would need to be offered testing as well. So what's really disappointing is that we have evidence that the uptake of genetic testing is very poor in relatives of individuals with Lynch syndrome. So one study that did a review of all of the articles that looked at this found that 52% or less of first-degree relatives, so these are those parents, brothers, sisters, sons, and daughters at the highest 50% risk, less than 52% are receiving genetic testing. And that is a major problem. And only one study that they reviewed included their data on second-degree relatives, but that, as you might imagine, was even worse at 15%. So one thing that we've looked at is, is it too much to kind of require the patient with Lynch syndrome to be the one who has to tell all of their at-risk relatives that they're at risk? And so that's called the patient-mediated contact of relatives. And it's important that, some of these patients have just been diagnosed with cancer. And so this is really a tough time to have to be then, on top of that, being responsible for telling all of their at-risk relatives that they might also have Lynch syndrome. Gavin, can you turn the light on in here? Sorry. So when we look at studies where there's patient-mediated contact of relatives, only 24 to 44% uptake of testing when the genetics clinic reports the outcome. And when studies where the patient themselves reports the testing outcomes, it's been reported to be somewhere between 15 to 57%. So again, not a good uptake. And around 33% of individuals, relatives, go unnotified or remain unaware of their risk. So we started to look at new mechanisms for notifying people who are at risk for Lynch syndrome, and one would be using a provider-mediated approach. So in this approach, the healthcare provider, so the genetic counselor or geneticist or gastroenterologist or oncologist, would take responsibility for notifying the at-risk relatives. One center improved their proportion of at-risk first and second degree relatives being tested from 23% using a patient-mediated process to 40% using direct contact of relatives. Again, still poor at 40%, but double what they were getting with just patient-mediated. It's not been studied in the US, but 66% of directly contacted relatives in Denmark preferred contact from the hospital rather than from their own relative. In a small US-based study at Kaiser Permanente found that provider-mediated approaches were acceptable from patients in the Kaiser Permanente clinics. So, this is something that we all need to start working on together, because I think input from our individuals with Lynch syndrome will be really helpful in figuring out the best way to improve cascade testing. But I know some people don't feel confident in the knowledge transmission, and even if you have a letter or fact sheet from the clinic, that still there's a lot of responsibility on you, and it's hard to answer those questions. So maybe having the help from your healthcare team would be useful. So you guys know, just moving on to the next way of identifying Lynch syndrome, and that's from testing tumors to see if people are more or less likely to have Lynch syndrome. You know that these Lynch syndrome genes are mismatch repair genes. So I tell my patients they're like the spell checkers in your body. And if there's a DNA spelling error when your cells are dividing, they recognize it and fix it. And because of those errors, tumors from individuals with Lynch syndrome tend to have microsatellite instability. So a lot of spelling errors in the tumor. Once the mismatch repair genes aren't working at all in the cancer, you can't fix those repairs. And so microsatellite instability is found in 15% of colon cancers and about 25% of endometrial cancers. And it's very good for detecting individuals with Lynch syndrome, but again, not everybody with Lynch syndrome has a tumor with microsatellite instability in it, so it's not 100% sensitive. The more common test is called immunohistochemistry, and this is a picture of what that looks like. And so when they stain someone's tumor to see if the 4 mismatch repair proteins are present, if they're present, you see the nice brown nuclear staining, and if they're absent, you don't. And so this is a sign that a person is more likely to have Lynch syndrome if any of the proteins are missing. And again, not 100% sensitive, but pretty good. And this is obviously really important, and we're having a little bit more luck talking hospitals into doing this for all their colon and endometrial cancers lately, simply because of the data that we all know for the last 5 years has been out showing that immune therapy is very effective in treating patients whose tumors have defective mismatch repair. So if you have a tumor with microsatellite instability, or your IHC shows that one of these proteins are missing, you are much more likely to respond to immune therapy, which is, you know, a good thing to have that additional treatment modality. And because of that, some oncologists are really trying to push their hospitals to screen for microsatellite instability in their patients' tumors for treatment purposes. Of course, we've been trying to convince people to do it for 20 years to figure out who had Lynch syndrome, but it doesn't really matter why, it's just we need to get it done. So when I first worked on the idea of universal tumor screening for Lynch syndrome, I worked with my mentor, Dr. DeLaChapelle, and we published our findings in several journals. This was a grant from the National Cancer Institute. And it started back in 1999 when we did a study on 1,500 colon cancer patients from the Columbus, Ohio area. And we checked for that microsatellite instability and found it in 12% of the colon cancer patients, and then proceeded to do gene testing and found that 2.8% of individuals with colon cancer had Lynch syndrome. And I remember when I first presented this data to the colon surgeons and oncologists, and they said, wow, that was a lot of work, Heather, for 2.8%. And I said, do you understand how common that is? Normally, genetic conditions affect like 1 in 200,000 individuals, and this is about 1 in 30 colon cancer cases. This is unbelievably common for something that's going to cause a high risk to half of that person's brothers, sisters, sons, daughters, and many, many other relatives. Endometrial cancer, same story, more microsatellite instability, but exactly the same prevalence of Lynch syndrome, which why it's boggled my mind that we've had a lot more trouble convincing hospitals to do universal tumor screening on endometrial cancers than we have on colon cancers for some reason. When we usually talk a hospital into doing their colon cancers, it takes them 3 years on average to add their endometrial cancers, and no reason for that when the same proportion are due to Lynch syndrome, essentially. You know, one of the things about the study was that we found that 50% of the patients who had Lynch syndrome were diagnosed after age 50. So some people only want to screen the young patients, well, they'd miss half the Lynch syndrome. The other really important thing is that 25% of the people with Lynch syndrome from the colon cancer cohort didn't meet those Amsterdam or Bethesda family history criteria we talked about. So even if their doctor was taking their family history and had these criteria memorized and referred the patients and they actually made an appointment and came, we would have missed a quarter of the Lynch syndrome. And the mutation spectrum is a little wider. We start to see more MSH6 and PMS2 mutations because they're a little lower cancer risk. And when you just test all comers, as opposed to people who come to clinic because of their strong family history, you see more of those mutations. In the 14 endometrial cancer patients, the data is even more striking. More than half were diagnosed after 50. More than half did not meet the family history criteria because they're very colon-based. And most of our endometrial cancer patients found to have Lynch syndrome on universal tumor screening end up having MSH6 mutations. We've been working since then. The first letter to the editor when we published that paper was, that's nice, but is it cost effective? Because even if it's the right thing to do, no one will do it if it's not cost effective. So we did a series of studies on cost effectiveness and proved that it is cost effective. It cost about $31,000 per life year saved. And for frame of reference, anything under $50,000 per life year saved is considered cost effective. So now universal tumor screening for Lynch syndrome is recommended in all colorectal and endometrial cancers and for consideration in other Lynch syndrome associated cancers by all of these professional organizations. So the surprise is that when we surveyed cancer centers in 2012, we found that 71% of the NCI designated comprehensive cancer centers were doing it, but only 15 to 36% of the community hospitals were doing universal tumor screening for Lynch syndrome. And 80% of cancer patients are diagnosed in these community hospitals that have the lowest adoption rates. So we have a long way to go, and I still spend a lot of my time working on convincing all hospitals to truly do universal tumor screening for Lynch syndrome. As you guys may have heard, last year they decided in England, in their national healthcare system, all of their colon cancer patients will be screened, and they are working on convincing England to start doing all of their endometrial. But in the US, we have to convince one hospital at a time since we don't have national health care. Now I want to talk about the idea of germline genetic testing for all patients with cancer. So the NCCN guidelines actually already recommend germline genetic testing for 3 different cancers. Ovarian cancer patients, metastatic prostate cancer patients, and all pancreatic cancer patients are recommended to have genetic testing offered to see if their cancer is hereditary at the time of diagnosis. But notably, they do not recommend genetic testing for all colon, breast, or endometrial cancer cases, even though the prevalence of mutations, so this is how many people will test positive if you test every single comer with colon, breast, or endometrial cancer, is actually higher than it is for pancreatic cancer. So this is something that, I think we as a group can advocate for with the NCCN, that we look at the data and make these recommendations based on the prevalence of mutations and not whether the cancer is common or not, and it's going to be a lot of trouble to offer testing to all of the patients. If it's the right thing to do based on the prevalence, then we should be recommending it for all of these cancers. We do have data out of Ohio State that certainly it should be offered to any colon cancer patient diagnosed under age 50. And what I mean here is that even if the tumor screening comes back negative and the tumor doesn't have MSI or abnormal IHC, every colon cancer patient under 50 should be referred to genetics. And that's because 1 out of 6, or 16%, have at least one hereditary cancer syndrome. About half have Lynch syndrome, but the other half had mutations in other hereditary cancer syndromes like BRCA1 and BRCA2, the breast ovarian cancer genes. And that might not have caused their colon cancer, but it sure is important for that patient and their relatives. So we'd like to do a multi-gene panel test for our early onset colon cancer patients, and we think all patients under 50 need to be seen in genetics, even if their tumor screening comes back normal. If their tumor screening is abnormal, they actually have an 83% chance of testing positive. If their tumor screening comes back normal, they still have an 8% chance of testing positive. And again, just looking at the Memorial Sloan Kettering impact data, where they've offered tumor testing and optional germline or hereditary genetic testing to all cancer patients at Memorial Sloan Kettering for the past few years. They've now tested 12,000 patients, and they've found that 17% had a mutation in a cancer gene. 6.5% were in genes with potentially therapeutic targets, so that could change their treatment, and your Lynch syndrome cases are going to be included in that 6.5%. But to see 17% testing positive, that's almost as high as the old numbers we've seen for ovarian cancer, where they recommend every single ovarian cancer patient undergo testing. And this really can change people's outcomes if they can get a treatment then that's targeted to their what's driving their mutation. So lastly, I want to talk about population screening. So this is when you offer genetic testing to everyone. You don't have to have family history or cancer. And the benefit is that you're able to identify unaffected people and potentially prevent them from getting cancer in the first place. So Geisinger has been doing whole exome sequencing for healthy adults in their health system in Pennsylvania for the last few years. And they have recently published some of their data on testing in the BRCA genes and found that 0.5% of the individuals they tested had a BRCA mutation. But interestingly, 82% had not been tested previously, 52% did not meet the family history criteria for referral, and it basically compared with clinical care, normal clinical care, and referring based on family history. Whole exome sequencing identified 5 times more individuals with BRCA mutations. They haven't released their Lynch syndrome data specifically, but they have released it as part of a study which I'm going to talk about here. So there are some people that are considering, and this is one of the things Color offers in some health systems, similar to the test that Elise got. But sometimes they just do these tier 1 diseases. Sometimes they do a panel of cancer genes, cardio genes, and medication response genes. But when they just do the tier 1 disease, those are Lynch syndrome, hereditary breast ovarian cancer syndrome, and familial hypercholesterolemia. And these have been denoted as tier 1 by the CDC because they're common. There is easy and accurate testing available, and they're actionable. There's something you can do about it to prevent bad outcomes if you know somebody has these conditions. So there's several ongoing projects offering testing for these diseases to the general public, including projects like the Color project that Elise was in at North Shore. Geisinger assessed for those tier 1 conditions in their 50,000 participants and found 1.3%, or 1 in 76 individuals has one of these 3 conditions. So that's adding our 1 in 279 to the HbOc frequency and the familial hypercholesterolemia frequency. And this is unbelievably common and really just means this is a public health issue that we need to think about that way. And just for comparison, you know, when newborns are born today in the US, they get newborn screening for a series of disorders that are rare but present in childhood and are treatable. The positive rate on that is 1 in 800. And the positive rate on these tier 1 diseases in the general public is 1 in 76. So this is something I think we really have to think about. And Elise's story really underscores how beneficial this can be. Her family had no idea they had Lynch syndrome until she was offered it as part of a routine screening in her primary care physician's office. That's a major success story because she found out before she got a cancer. The Healthy Nevada Project did something similar. They tested for the tier 1 conditions in 23,000 so far individuals in Nevada. And again, 1.26% had one of these 3 conditions, or 1 in 79. So we're getting really tight estimates for the frequency of these conditions. Over 90% were undetected in current medical practice. Less than 20% had any documented suspicion in their electronic medical record, and less than 40% had a family history consistent with the disease. So a population preventive screening approach for people under age 45 may really improve outcomes and prevent cancer and heart disease in the case of FH. I just want a minute to talk about being aware or beware of direct-to-consumer tests. So Elise's first test was a test that you can get through the internet, which offers a health screen and ancestry testing and this kind of thing. But they only look at a few genes when they look at the cancer genes. They look at the 3 common Jewish mutations in the BRCA1 and 2 genes. That'll actually miss 90% of BRCA1 and 2 mutations in non-Jewish individuals and 20% of BRCA1 and 2 mutations in Jewish individuals. So it's not a good enough test. If you test positive, it's helpful, but if you test negative, you still could have a hereditary cancer syndrome or a BRCA mutation in that case. The only colon genes they do at all are MUT-YH, and that causes a colon polyposis syndrome. They don't do any of the Lynch syndrome genes. And so the concern is that if you test negative and are told you're at low risk for colon cancer, you may be misled into thinking you don't need to worry about this. And in fact, Elise thought she was in good shape until her primary care physician said that test was not complete. You need a more thorough test. And to that end, Color does offer direct-to-consumer testing, which is adequate. It looks at these genes specifically, all of the cancer genes, all of the cardio genes, and medication response genes. So not all labs are created equal, but you have to be careful what you're getting into when you do direct-to-consumer testing. So in conclusion, cancer genetic testing can be very valuable to individuals in terms of cancer prevention, early diagnosis, and treatment. I think you guys would agree with me on that. In the past, though, we only offered it to high-risk families and affected individuals in those families. And we're now in this transition period where it's being offered to all patients with certain cancers, regardless of their age of diagnosis or family history. And some centers are even offering genetic testing to all cancer patients with promising results. So should we really be waiting until individuals get cancer, or focus on testing healthy individuals in hopes of preventing cancers? And ongoing studies will help us answer that. And in the meantime, I feel like Lynch syndrome is so underdiagnosed that we have to do all of these testing processes: family history-based, cascade testing, cancer patient testing, and general population testing, because we have a lot of people out there who have Lynch syndrome who don't know about it, and we have a long way to go. Thanks so much.
So thank you both for doing this, and we do have some Q&A. I will say this, a couple of things. So the questions and the comments are rolling in, which is great. I truly appreciate it. My job as moderator is to try and keep them segmented so that we stay within time limits. So if we don't get to your question or comment for your clinician or patient of choice, I apologize. We will get to everything today. It just may not be in the beginning. So, so the first question we do have is for Elise. So, Elise, so the question that came in is, what active personalized medicine did providers put in place for you after your Lynch diagnosis?
Yeah, so after I met with the Center for Personalized Medicine at North Shore, they put me in touch with an oncologist, a gynecologist, of course, a gastroenterologist, and a dermatologist. And so I made appointments with all of them, and they gave me screening recommendations. And so for the gastroenterologist, I saw also a question about screening, so I'll answer that too. The gastroenterologist had me do an MRE, which, if I'm correct, I think is an MRI that has specific contrast that helps look at the small intestines and the bowels. And then I did an upper endoscopy, and of course a colonoscopy, as we all have done, and a transvaginal ultrasound. The gynecologist had me do that. And then of course this full body skin check with the dermatologist. So to get all those baseline screenings done.
Awesome. I think that actually that answered the second question, which was what type of baseline screens were recommended. So you're the big winner in this one. So Heather, just willing to let you know that a big thank you came in from somebody that thanked you for recommending a clinical trial for immunotherapy. So kudos to you for that. Also, can you, here's, forgive me if this is a silly one, but, and there are no silly questions, so trust me. Can you define what germline means?
Yeah, that was a good one.
Meant to stump you. This is a question coming from the audience.
I saw it, and I felt bad that I didn't define it in my talk. So germline mutations are mutations you inherit from your mom or your dad. It means that it came from an egg or a sperm, so that's the fancy word, but a lot of people react to that term negatively because it sounds, in today's current climate, like something infectious, right? So it's not a germ, it just means it came from your mom or your dad in the eggs or the sperm, and so you inherited it, and that's the genetics that's sort of in every cell of your body from the day you're born. And when you have Lynch syndrome, you're born with a mistake or a variant in one of the mismatch repair genes. And so because you're born with it, you can then pass it on to your children. And the reason I said germline so much during the talk is that there's also testing being done currently. One of our sponsors, Foundation Medicine, actually does it, where we sequence people's tumors. And there we're looking for mutations that occurred in someone's body during their lifetime that cause their cells to start growing out of control and become a cancer. And those are mutations that are acquired, not inherited, and can't be passed on to the children. And so I try to distinguish between the two because a lot of people now get both types of genetic testing. Usually when we're doing germline testing, we use a blood sample or saliva sample. When you're using tumor testing, they'll actually use a piece of your tumor that was removed during surgery.
Gotcha. Thanks, Heather. Yeah, as everyone can tell, we are all coming in from our home offices and whatnot. So we have dogs barking, trucks going by, trains going by. So you, by no means are you guys alone. We're all in it. So please accept my forgiveness in advance for any time the sound comes through. Different question, guys. Age recommendations for testing someone. It was a specific question regarding a first-degree relative, but quite frankly, I think this could be a general question. Any age recommendations for genetic testing? And Elise, the future genetic counselor, can chime in as well as Heather, but I have a feeling this will be one Heather will jump on.
I do too, but I think Elise might be able to give us a really important perspective. So typically for Lynch syndrome, we don't offer genetic testing until someone reaches adulthood, so age 18. Some exceptions are made if there's really young cancers in a family, but typically the screening doesn't start until after that. And so 18 is the earliest we would offer genetic testing to an at-risk individual. And then, of course, we like to make sure that testing is done before they need to start screening. And that used to be the same for all of the different Lynch syndrome genes, that the colonoscopies would start somewhere between age 20 and 25. And so I used to just tell everyone, get tested sometime between age 18 and 25. That way you know before you need to start your colonoscopies, and you don't have to start colonoscopies, more importantly, if you don't need to, because maybe you didn't inherit the mutation. I saw the question over in the chat, and I think it was specific to MSH6, and that may be because just this summer, the NCCN changed the guidelines for MSH6 and PMS2 mutation carriers, and they now say you guys don't have to start your colonoscopies until age 30 to 35. And so technically, an individual with an MSH6 or PMS2 mutation could get tested anytime between 18 and say 30 now. They have a little longer window because none of the screening really would start until then. And so I don't know, Elise, did you, I mean, you kind of got tested a different way through your primary care doc, but I notice my patients, sometimes some people are there on their 18th birthday because they've known the family has Lynch syndrome and it's been part of the family and they're really anxious to know. And I have others where that's kind of a prime time in life. They're starting college and they'll say, I see you after college, Heather. And I see them around 22 to 25. I don't know, how did it feel for you?
Yeah.
You're pretty...
As you mentioned in your talk right before this, I had no idea what Lynch syndrome was, that it existed before my primary care physician brought up doing this genetic test, which I'm so glad that she did. And so I was tested when I was 26. And so, yeah, and at that time, getting a colonoscopy, even with MSH6, was recommended. And so I did do that.
Right.
And then found out that I didn't need to. But I mean, honestly, I feel better that I did
Right.
it and have that baseline. But yeah, I think it's interesting that had that not happened in my life, just seeing that specific primary care physician and the color genetics, all of that happened, to this day, I definitely would not know that I had Lynch syndrome.
It's an amazing story.
Yeah.
So for the record, I have not reached adulthood yet, but I have been tested. So
Okay.
just wanted to put that out there. So Heather, so the real quick, in the last 2 minutes before we need to segue, are doctors becoming more aware of Lynch syndrome, and how can the average person improve awareness? And while people do that, while you answer, I'm going to hold up all the brochures that we have that people can use to hand off to their physicians and their genetic counselors so that they are aware of Lynch syndrome and Alive and Kicking and the Colon Cancer Coalition. Did I answer that already?
Yeah, no, I mean, I sure hope clinicians are becoming more aware of Lynch syndrome, but every day I hear from patients who tell me that when they talk to their doctor about it, it was the first time they had heard about it. And I always say that's okay as long as they're willing to learn, right? If they're not willing to learn, you might need to look around for a different healthcare provider. But as long as they're willing to learn, then you can take those materials to them. Most academic centers that you might have worked with where you're testing have fact sheets that can be used, letters with recommendations. Alive and Kicking obviously has materials, and so do lots of other professional organizations. So sometimes you're going to be in the position of teaching your healthcare provider about Lynch syndrome, but as long as they're open to that and are willing to, be your quarterback and get all of your screenings ordered on time, that's fine. It's just if they don't seem open to learning that you might need to advocate for yourself a little. And of course, we're all trying everything we can do to increase awareness, but it has a long way to go. And I think, you know, many more people now are aware of hereditary breast ovarian cancer syndrome and the BRCA1 and 2 genes. And I think partially that has to do with Angelina Jolie and her op-ed pieces discussing her diagnosis. You know, hopefully over time, Lynch syndrome will become more well-known and commonplace, because I think it's just, unfortunately, people don't even put together the idea that, oh, if my sister had a uterine cancer and my dad had colon cancer, they could be related. It just isn't something that I think is common knowledge at this time.
So what Heather's saying is anyone who wants some material to hand off to their physician or genetic counselor, make sure we have your email and address and phone number and a way to get you some material, and we'll be happy to send it your way. And by all means, educate your physicians. So my job as moderator is to continue the process. So thank you, Elise and Heather.